Thanks, Rio. I'm actually going to introduce Paul. My name is Emily Kirchner. I am the event coordinator here at the National Registry. Thank you all for being here, and a big thanks to the National Association of EMS Educators for hosting us today. A couple points of housekeeping before we get into things. Today's webinar will run for a maximum of 1 hour, and we absolutely welcome questions, so please submit them via the Q&A function. We will be answering them in a dedicated session at the end of the presentation. And we appreciate your partnership. We're very happy you're here today. And with that, I'll hand things over to Paul.
Thanks, Emily. Yeah, so today we have 4 objectives, and these are objectives. We kind of want to talk about the methods and concepts related to assessing clinical judgment. This is a topic that could actually take 2 hours alone, so we're just going to touch it today. But we are going to spend a little bit more time on a scenario that's available on our website so that educators can get familiar with the content as well as share the content with their students. And again, this is publicly available, and we want you to go there and take your students to this site as well. So we'll spend a good bit of time on the scenario. We'll then transition and we'll look at items that are currently on our examination, the conventional items. We'll then also look at some of the new items that are out there being piloted at this time. We'll then briefly talk about the SMC for both the AEMT candidate and the paramedic candidate, and then conclude with skilled scoring reports. And with that said, that is the agenda for today. So let's get into our first section, and that is the performance component of the ALS examinations. The the new content to the examinations, the performance piece of this is going to measure the concepts of clinical judgment, leadership, and communication. So if you haven't seen this graphic before, we've been out presenting the graphic for at least about 18 months now, but this is the theoretical proposed concept of what clinical judgment looks like in EMS. There were 4 primary researchers who tried to determine exactly what clinical judgment was in EMS. And on the next slide, I actually have the article that's published in the paramedic or pre-hospital emergency care journal. And I will share that link with you so that you can go dig into that article further. But to kind of explore this concept of clinical judgment, you'll notice a lot of things in this graphic. The first one is this concept of clinical judgment. It's the blackened font with the big bar that goes across the entire screen here. And it's the concept of clinical judgment. Clinical judgment really is 2 things. It is the reasoning that clinicians use and the decisions that they make, which shows up as a judgment of some sort in the field. And so with those 2 things combined, we then have clinical judgment, reasoning and decision-making by our clinicians. Clinical judgment also encompasses that role of leadership, leading the scene and leading the team to take care of a patient. And it also involves communication, communicating with lots of people, with the patient, with our peers on scene, with the hospital, with doctors, with bystanders, or whoever else is on a given scene. So clinical judgment is 3 things: decision-making, reasoning, it's the leadership and the communication. And in this particular model, what they found when they did the research was, and this is not new to anybody here, there's 3 phases to an EMS call. There's an en route phase, there's a scene phase, and there's a post-scene phase. So we know that there are 3 phases of a call. And if you drop down to the midsection here with the circles, you'll note that each circle has 6 steps, and these are actually the steps in the clinical judgment. That first one being is we recognize cues, we analyze cues, we develop a hypothesis, we generate some solutions, we take an action, and if we're a really good clinician, we reevaluate and adjust our therapy based on that reevaluation. If you look across all 3 phases of the call, we're doing the same things. So the en route phase has those 6 steps, the scene phase has the same 6 steps, and the post-scene phase has the same 6 steps. So I can illustrate the scene phase really nicely here. When we arrive bedside to a patient, we look at the cues that we see in the environment, as well as with the patient. And so we start recognizing things that help us clue in as to what we're seeing and what we're dealing with the patient. From there, we analyze those cues to determine what's concerning, what's relevant, what's not concerning, or what's not relevant. After examining those cues, we come to a hypothesis. I would tell you this is a general impression of our patient. From there, we know that there are various therapies for any type of clinical impression. We work through those. We select the solutions that are appropriate for that patient. We implement that action, and then later we look at our patient and make sure things are getting better and not worse for that patient. And so those are the 6 steps in the model here, but you'll notice that there are 6 steps in each of those phases. Those cues are enriched from what we see with our patient, what we see in the environment. And of course, there's provider factors such as, am I an EMT, or am I an EMR, a paramedic, or an AEMT? And so again, what are my capabilities as a clinician? What is my scope? What is the things that I can and can't do to take care of a patient? So all of that comes together, and the candidates are going to be asked in a scenario, some questions en route. What are the things that they would do en route? They will ultimately make the scene. They will then be asked some questions about what are they going to do on scene. And then finally, they'll transition to that post-scene phase and be asked questions post-scene. And so what you see here is the opportunity for 18 items in a scenario. So there could be up to 6 items on scene or en route, 6 items on scene, and then 6 items post-scene. The reality of it is in time, I think the candidates will see only about 9 to 10 items per question. But those combinations could be 3, 3, and 3, 3 en route, 3 on scene, 3 post-scene, or it could be 2 en route, 4 on scene, or 4 post-scene. But that remains to be determined as we implement and pilot these clinical judgment scenarios. But that is the model as to what clinical judgment looks like. If you want to know more, the Pre-Hospital Emergency Care Journal found on this slide is actually the document that shares the information on what clinical judgment is and how these doctors, Dr. Aguju, Dr. McKenna, Dr. Platt, and Dr. Panchal, discovered as they tried to develop a model for us for clinical judgment. So this is a really nice model to define what clinical judgment looks like in EMS. And from that, we're able to measure clinical judgment on the certification examination. All right, so let me transition here and let's go experience one. So what I have done is I've transitioned to the National Registry website. On this page, you're going to see National EMS certification for the 4 levels, the EMR, the EMT, the AEMT, and the paramedic. And so if you want to go to experience a scenario, all you have to do is click on certification at the AEMT or the paramedic level and follow the prompts here. So I've clicked on advanced EMT, and I'm going to go to this area here called full education program, learn more. And it takes me to a page that explains the process for a candidate to test as an AEMT. On the right, you'll notice there are quick links, and the top link here is this new experience an interactive performance scenario. So again, this is publicly available. You are quite capable of following me into this if you'd like. But this is the link that I'm going to click on. And it's going to take me to a page that's going to look remarkably similar to what a candidate would see in the test center. And so this is actually on our testing vendor's website. This is actually not even on the registry website, but this is extremely similar to what they will see in the test center. So this first one explains to them, how to navigate this scenario. And it's really written for people going and visiting this website. So it explains everything that's going on. We don't have time for me to read all this, but when you navigate there, you can take your time and read all of this. So I'm going to hit the button that says next. And this would take us to what a test would look like for a candidate for clinical judgment. So I want to show you a few things on this. On the left here, we have the actual scenario. You'll note that there are 3 tabs: en route, scene, and post-scene. Being that the candidate has to answer the en route questions first, this is the only bit of information that's provided to them right now. So the en route phase is lit up. If I try and click on scene or post-scene, we cannot go there yet because we have to answer the items that are related to en route. On the right, we have the actual question. And so, for instance, this question is a multiple response item. I'll talk about this more later in the presentation. But in multiple response item, we're asking them to select the correct answer options related to the text. And so let's just read this. So the en route information that's provided says the AEMT is dispatched to a dentist office for a 32-year-old patient who is weak, dizzy, and slightly agitated. The time of the call is 10:15. The response time is 9 minutes. So we kind of have got the setting there. We're going to talk a little bit more. The AEMT is partnered with an EMT, and a BLS fire department engine crew is dispatched with the ambulance. So those are the resources. The patient's located inside the office. There's heavy rainfall in the response area. It's a cool spring morning and the temperature is 42 degrees Fahrenheit, 6 degrees Celsius. A small hospital is located 12 minutes away, and the nearest comprehensive medical facility is 30 minutes away. So that's the information that they have in the en route phase. So we then move over to the item, and it says identify the dispatch information cues that the AEMT should prioritize for response and scene readiness. Select 2 answer options that are correct. Do note that at Registry, we tell the candidates how many correct answers there are in a multiple response item. And so a lot of testing bodies will say select the appropriate answers. We will tell the candidate there are 2 or 3 correct answers that they need to select. So if I'm the responding AEMT, I am concerned with this fact that the patient has agitation, and also the rainy weather may hamper my response. And so if I were to answer this question, those are the 2 that I would pick. But I want to show you something that is kind of fail-safe for the candidate. If I try and hit a 3rd option, the test will not accept that. And so it says you've already selected the maximum number of options allowed. So I have to go back to that and unselect something. If I only select a 1 answer option and try to go to the next option, again, I get a message that says, nope, you have to select 2 answers. And so the result of this is the candidate has to pick 2 answers to move forward in the test. So before I do that, let's get the right answers here. This agitation and rainy weather could be a problem. And so that's how I would answer it. I then move to the second item. This item here is multiple choice. And so again, the content on the left did not change. The item did. And so it says, which of the following leadership roles should be considered en route for this patient? If you remember earlier, I said there was clinical judgment, there's leadership and communication items. And so this particular item is about leadership and it's multiple choice. So what should be done regarding leadership en route? And so I would assign responsibilities to my teammates to take care of this situation, and I would answer it that way. I would also now go to my 3rd item, and this is multiple choice. There are 3 or 4 options. It says, what factor for this scene may allow for more precise communications to occur than would occur on many other scenes? And so again, here's your communication item. The answer here is, being that we're on scene at a dentist's office, we have a dentist, probably some hygienists and others. We probably have access to medical records, and so we probably have a wealth of information about this patient. So I'm going to pick letter C that says healthcare providers are with this patient on scene. So we probably have good information. Okay, and so there are 3 items there for the en route. Note that the test now has moved on. On the left, we have the tab as seen lit up and highlighted. And there's new information. The question on the right is seen. I can go back en route and look at that en route face if I want to, if I have information I need to see. But we're going to go to the scene and answer the questions here. So we make the scene. The patient is 60 kilograms sitting awake in a dental suite and does not want to be bothered. The office staff states that the patient reported feeling weak on arrival for the appointment and then became confused. The patient has a history of seizures, diabetes, and hyperlipidemia. The patient was told to fast after midnight for a dental procedure. Medications include insulin that's being administered by an automated external pump, seizure medications, medications for pain, and a statin. The patient has no allergies to meds. And when we look at the patient's skin is diaphoretic. There are no signs of trauma. The patient obeys commands. The eyes are open. The pupils are 5. They are reactive. The vital signs are 156/90. Pulse is 124. Respirations are 10. SpO2 is 95%, and the temperature is 98, 38 degrees Celsius. And the blood glucose is 47. So that's the information that they're presented with on scene. So the question is a multiple response. It has 2 correct answers. It asks, which of the following findings are most significant for determining the nature of illness? And so I think what is really important here is the fact that this patient is taking medications. They're on an insulin pump. They've been instructed to not eat after midnight, and now they have an altered mental status. The environment, I don't know is all that important. The respiratory rate at 10 is not abnormal. The pulse oximetry at 95% is normal as well. So if I were trying to determine the nature of illness for this patient, I would look at these 2 things as being very critical. The next item, again, this is seen. Another multiple response asks me to select 2 answer options. It says, based on the patient's observations, which of the following conditions could explain the patient's current state? I don't think this patient is hypoxic. I don't think this is a side effect of the statin. I do think this patient's had too much insulin. I think the patient has not enough food because they're fasting. And this is not advanced mixed edema. So I'd answer the question in that way. And now there's another scene question. And I'm going to cover this here in just a second. But this particular item is called a drag and drop. And so they're going to follow the commands that are in the question and drag and drop the content into the appropriate boxes here. So the question is, based on the patient findings, what is the most probable medical emergency and what is the correct treatment for that emergency? Move the most probable emergency into the answer area and then move the correct treatment into the answer area. And so I don't think this is an opioid overdose. There's nothing there to say that this is the case. The pupils are 5. They are reactive to light. The respirations are adequate. So I would not go with opioid overdose. I do think I see everything that says this is a hypoglycemic event. So I'm going to move that over. And just to make sure that this isn't a seizure, the findings are not consistent with the seizure, so I would not select that. My therapies available for this is to give dextrose, which is the answer I'm going to pick. There's no reason for Narcan, and there's absolutely no reason for supraglottic airway. And so I would drag those 2 over, put them in the answer area, and move on to the next item. This is a drag and drop. My next question is, which of the following initial signs and symptoms is consistent with early onset hypoglycemia? This is a multiple choice. And the best answer here is this altered mental status. Next question, what treatment should AEMT perform next? Select 2 answer options that are correct. So there are 2 therapies here. And this patient has a sugar of 47. So I'm going to start an IV and I'm going to give dextrose. There's no indication for oxygen. Again, the patient is not a narcotic overdose. And I would start with the IV and dextrose before I would go on to glucagon. The glucagon would be my backup drug. I would select those two answer options and move on. Now I've gone to post-scene. So the tab on the left is now lit up as post-scene. The item now is identified as post-scene. I can go back and look at my scene information. I can go back and look at my en route information, but I need this information to answer these items. So despite successful dextrose administration, the patient remains weak and dizzy and vomits. The patient is severely confused and has pale, cool, diaphoretic skin. The patient is shivering, is not following commands as remove the IV line. So there's a status change here. Eyes are open, the pupils are 5 and reactive. The vital signs now are 160/92, pulse 130, respiration is 12, SpO2 is 95%, and the temperature is 98, and the blood glucose, despite that administration, is only up to 52, which if you remember on scene, it was 47. So it's come up a little bit, but not much. So let's go answer the questions. Because of the observed patient changes, which of the following actions would be beneficial? Select two answer options that are correct. This patient now is vomiting, so we need to get out our suction. And what else do we need to do here? No reason for oxygen. Yep, no reason for oxygen, no reason for narcotic overdose. And the blood pressure is 160/92, so there's no reason for fluid administration. So I would stop the insulin pump and move to the next item. Post-scene, which of the following therapies should the AEMT consider at this time? Select two answer options that are correct. So I would regain IV access, and I would continue on with the dextrose administration. Again, there's no reason to ventilate with the BVM. There's no reason for a fluid bolus. And this patient is not able to protect their airway because they're severely confused. And I would not give oral glucose. So I'd answer those items that way. The next item for the patient's related condition, which of the following medications could the AEMT anticipate using? And so we've got vomiting now. So the therapy would to give them Zofran. Again, there's no reason for Narcan, no reason for aspirin, and no reason for epinephrine. The next item here is what we're calling a build list. And this one is one of the new TEIs, and it says what conditions are likely to explain the patient's continued signs and symptoms despite appropriate therapy. Move the three answer options to the answer area and order them from most to least likely. So I think we all agree that this patient has hypoglycemia. So I've clicked on that. I'm going to toggle it over, put it into the number 1 spot saying this is what I'm treating. Oops, hold on, I can fix that. Let's move this one over, put that up into the top spot. And this is also a hypertensive issue, but that's not really what I'm treating. It's not my priority. And I don't think the patient is cold because their temperature is actually 98. So I think the most likely is this hypoglycemia because of all the signs and symptoms and the history that we're getting, and the fact that the sugar is 52. The patient's blood pressure is slightly elevated, so I'd slide that into the number 2 spot. And of course, I really don't think the patient's hypothermic, so I put that in the least likely spot. And when I got those in place, I will hit next, and that will answer that question. The third novel TEI that we're using is this one where I call it an options box. So we ask, put things in the right bucket here. So if the patient's improving, what would we see? If the patient's not improving, what would we see? So the question asks, what changes to the patient's signs and symptoms would indicate that treatment is improving the patient's condition, and what changes would indicate that despite treatment, the patient's condition is worsening? Select two options that would indicate improving, select two changes that would include worsening. So I'm going to come over here and look at the heart rate. The heart rate is 130. So if that heart rate increases more, I would think that would be a bad thing. If the patient starts following commands, I think that would be a good thing. If the skin became dry, if you remember it was diaphoretic and cool, that would be a good thing. And if the patient experiences a seizure, that would be a bad thing. And so I put the answer options in the right box. And when I'm done, I hit next. And that concludes the demonstration. But the key thing that we want to share here is that That is available on our website. You can go to that. You can experience that yourself. And we would really encourage you to show your students that as well. So that is the experience. And this again is where you can find that on our website. It's actually on our website in 3 locations. These are the easiest 2. Again, we navigated here under the AEMT tab, as well as the paramedic tab. And if you go to the quick link, notice it says new experience and interactive performance scenario. And that will take you to that demonstration that you can go to whenever, however you want to. All right, so transition now into the item types that we're using at National Registry. So I put these in 2 categories. The first category is this of conventional or existing items. These are items that currently are on our examination and actually have been on our examination for at least 2 years. And then the novel items, these are the items that are being put on our examination right now and being piloted on our current examinations. So let's talk about the conventional first. So in that scenario, you just saw several multiple choice items. With a multiple choice items, I suspect everybody here is very familiar with them, but there is 1 correct answer, 3 incorrect answers. And so in this case, it says, which of the following signs and symptoms is associated with asthma? And the answers options are coughing, stridor, ascites, or slurred speech. And I would answer, it is the coughing. So they would pick the 1 right correct answer and not select the 3 incorrects. Here is a multiple response. We actually use 2 types of these. In this case here, you'll see that there are 6 answer options. And so this one asks the candidate to select the 3 answer options that are correct. And so we're saying of the 6, 3 of these are correct. And so this one says, which of the following signs and symptoms are associated with asthma? So we got coughing, wheezing, and shortness of breath selected. The stridor, the ascites, and the slurred speech would not be associated with asthma. And so I would not select those. But do note that there are 3 correct answers. There's 3 incorrect. If this was a 5 answer option, you would see the instruction to say select the 2 answer options that are correct. So again, here you would see 3 incorrect answers, whether we're using a 5 or a 6 answer option. So if there's 5, there's 2 correct answers, 3 incorrect. If there's 6, there's 3 correct answers and 3 incorrect. So the last conventional item we're using are EKGs or graphics. And so our test items could include a normal basic EKG strip, or they could include a 12 lead. And then we would ask a question related to the graphic that the candidate saw. And so they would answer, in this case, it says which region of the myocardium has most likely been injured based on the ECG below. So then they would select anterior, posterior, lateral, or inferior. And of course, the graphics are on our test now. The new items are the novel items. And so you just saw one of these a minute ago. But here it is. It says, what is the relative level of concern presented by the patient's signs? And so again, this is related to the scenario we just saw there. If I was to answer this item, this is a PowerPoint here, so let me go to the next slide. I would place them in this order. If you remember, the blood sugar on this patient was 47. So that would be most concerning to me. I believe the heart rate was 100 or 104. I don't really remember. But I think that heart rate is a little tachycardic because this patient is experiencing insulin shock. And I would think that that heart rate would resolve when I correct the hypoglycemia. So I put that in the number 2 spot. If you remember, the pulse oximetry was 95% on room air. That would be my least concerning sign of this particular patient. So I would order them this way, from most to least concerning signs and symptoms that I see with my patients. These loan themselves also to sequencing. So for instance, if we wanted to say, what would you do first, second, and third? We could actually just put it into this type of item and say, okay, identify your first step, your second step, and your third step for taking care of this patient or managing the scene. So again, what you see here is these items work really good for sequencing therapies, but they also work well for sequencing the most severe to the least severe signs and symptoms that a patient's experiencing. We saw a minute ago the drag and drop. So this one here again is related to that same scenario. It says for this patient, which of the clinical findings below are related to determining a working impression of a hypoglycemic emergency? And so I would just pick these up and drag them over to the right spot. I'd put them in the right spot, and I would say for this patient who has a sugar that's low and they are symptomatic, I would think that the signs and symptoms that are related are the uncooperative behavior, the blood sugar of 47, and the fact that they're using insulin despite the fact that they're fasting. I would think that what's unrelated is this respiratory rate of 22. That could mean a lot of different things, not necessarily hypoglycemia. The statin use may or may not be related to the hypoglycemia, probably not. And the history of hyperlipidemia is not going to be causing the emergency that we're answering today for this patient who has an altered behavior and a mental status and a sugar of 47. So again, I would just drag and drop these and put them into the right spot and answer the item. This one here is not related to the scenario, but it's an example of an options box. And in this case, there's two categories that we're placing signs and symptoms in. So it says, what are the features of left-sided and right-sided heart failure? Select the 3 signs that are left-sided and the 3 signs that are right-sided and put them in the right spot. So when you examine your patient, we know that edema in the legs is a right-sided heart failure finding. So I would click on that. Pulmonary edema would be a finding for left-sided heart failure. Pink frothy sputum would be a finding for left-sided heart failure. Engorged neck veins would be a finding for right-sided heart failure. Ascites would be a right-sided failure finding. And PND would be a finding for left-sided heart failure. So the candidate would just point and click and answer all those areas. And when they got that done, they would then hit next, and they would indicate their answer options for that particular item. So what you just saw there was our conventional, the multiple choice, the multiple response, and the graphics. And the 3 novels that we're introducing, the build list, the drag and drop, and the options box. And so those items are currently on our examinations and being piloted or being used as operational items. So now I'm going to transition and talk about the psychomotor and what's happening to the psychomotor. So the psychomotor examination for the ALS test is going away, and this is the timeline. And when I say ALS test, we're talking about the AEMT provider and the paramedic provider. The BLS psychomotors will continue to be in the domains of the state. And so whatever the state that you work in will continue to dictate, what the psychomotor looks like for the EMR and the EMT. But going forward, the psychomotor will be retired at the paramedic and the AEMT level, and this is the timeline. So if you have a candidate, let me explain this, it gets really complicated, but a candidate who has passed the cognitive examination prior to June 30 or on June 30, they pass on that particular day, they have the option to go into the psychomotor process. And they'll be able to do the psychomotor examination for up to 1 year. That will be July 1, 2024 until June 30th of 2025. They'll have 1 year to get that psychomotor examination done. If they don't get it done by June 30th, 2025, they will have to take the new examination. But they can take the new examination July 1st and never have to do the psychomotor examination. But if they have a cognitive pass on July 30th, 2024, they will have 1 year to complete the psychomotor process. And so after that particular date, National Registry will no longer support the ALS psychomotor examination at the AMT or the paramedic level. That will be picked up with the performance examination, which is measuring those concepts of clinical judgment, leadership, and communication. And I'm sure we'll have questions on this, and we'll come back to the slide as those questions pop up. So the question we often get is, okay, so we're no longer testing psychomotor competency. How do we know candidates are competent in their psychomotor skills? And so on the right, the COA has created an SMC that captures all those skills at the paramedic level. And so when you meet those requirements of the paramedic SMC, that will be documentation that a candidate is competent in those psychomotor skills. And if you remember, this is a portfolio of skills that starts on day one of the class and ends on the final day of class. And what you see there is that a candidate has been able to perform a skill throughout the entire course. And they've done it in many settings, such as the clinical hospital sites, the field internship, or the field capstone, or even in the lab. And so with all those documentations of skills proficiency, that is very adequate to demonstrate that they're competent in their skills, and that alleviates the need for a psychomotor examination. On the AMT side, something very similar is happening. Instead of working with COA, National Registry is working with the National Association of State EMS Officials, and we're working on a portfolio SMC for the AMT candidate. That is in the process, and that is going through a lot of committees and task force that is being worked on by NAEMSE as well as Registry. And hopefully that document will look very much like the paramedic document. And it too will capture patient exposures and a set of skills that an AMT candidate would capture or do in the lab, at the hospital, at the clinical site, or during field internship or field capstone. Again, we capture a lot of skills in a portfolio from the first day of class to the final day of class in multiple settings. And again, that demonstrates the psychomotor competency, which alleviates the need for a skills checkoff at the end of the course. And then finally, the last topic, and we got lots of time for questions, is this concept of scaled scoring. So very soon here this summer, and I'll show you the timeline on the next slide here, Registry will be moving away from the domain level scoring and moving towards this concept of scaled scoring. And so what a candidate who has failed the examination will get is a document that looks much like this. And it will say that the passing score was 950, and it will tell the candidate how far they are from the passing score. And so in this example here, this particular candidate has scored an 850, which is not quite enough. And so they would be notified that they have failed the examination, and this is how far they are off of the mark. Why are we doing this? Because the scaled scoring will provide a better and more informative feedback for future successful attempts. Instead of saying that you're near passing, below passing, and all of that, this will actually give them a score as to where they are and how far away they are from passing. The past rationale for this is, the incomplete conclusions have been drawn by candidates because they weren't really sure what they needed to do to prepare for the next examination. And this is going to be a little bit more informative to them. In reality, what we typically see is a candidate who has failed the examination isn't weak in just one or two areas. They tend to be weak across all those domains, and this is going to show them how weak they are. So somebody scoring a 400 clearly is not ready. Somebody who's at an 840 or a 900 is much closer than that person who was at 400. And so additional reasons, it is industry standard to report scaled scoring, and it is an accreditation requirement for the National Registry to provide scaled scoring. When will all this happen? We're going to start introducing the scaled scoring on June 1st. Again, I'll repeat that this is only for candidates who failed the examination. And by September 1, we will remove the domain level feedback. And also on September 1, there'll be new reports that are available to program directors as well as EMS state directors to look at the results of various schools and be able to compare that on a national scale. And then finally, if you want to know more about this concept of clinical judgment, this is a shameless plug that there will be about a 6 to 8 hour course titled Educating and Evaluating Clinical Judgment for AEMT and paramedic educators. It is going to be hosted on August 16th. It is a pre-conference date for the annual NAEMSE annual symposium. It is free, but you must register. So if you're coming to symposium, you might want to come a day early and attend this event. Again, it's free. Again, it's going to be sharing information about clinical judgment. How do you educate it? How do you evaluate it in the AEMT and the paramedic program? And so this is going to be taught by some very talented instructors who are heavily involved with NAEMSE. And I think you'll get a lot out of it. So shameless plug for this particular event. This is on the NAEMSE website for registration. But if you get the chance, it's probably worth your time. And that's all I have.
Okay, Paul, excuse me. So your first question comes from Katrina Adelman in reference to the performance component. So this is done on a computer and not by an evaluator?
That is correct. So Katrina, this will be when they come to the Pearson VUE site, they will sit down and they will take a portion of the test that will gauge their cognitive ability. And there'll be another portion that gauges their performance or that concept of clinical judgment. It will be graded as a single examination. This will just be another domain area. Like currently there's ARV, trauma, cardio, med-OB-GYN, operations. This will be a new domain for those candidates. Again, this will all be scored as one test, not separate domains. And they'll be able to do that at the test center at Pearson, which will then alleviate the need for a psychomotor examination that's required by National Registry when this is all in place. Great question.
Okay, your next question comes from Angel Burba regarding the scenario-based questions. Are there any test banking vendors out there who are attempting to create questions in these formats?
You will have to check with the vendor that you use, but I will tell you last summer, July and August, we did a summit for vendors who write items like this. And so we spread the information to those vendors. There were a lot of those vendors in attendance of that. And my guess is they're in the process of developing these type of items. But that was shared last summer with those vendors. Is any of those vendors have those available at this moment? I don't know the answer to that. But if they're not available right now, they should be pretty doggone soon.
Okay, your next question comes from Daniel Forbing regarding the scenario-based questions. Has anyone taken this exam yet, and are the outcomes good or bad?
Yes, so these are on our examinations now at the AEMT and paramedic level. We are capturing the metrics behind them right now. And when we have the metrics we want, we will examine them and determine how they actually perform for us. And so it is in a pilot phase right now. The analysis of that data has not come down yet because these items are still being tested right now. And I don't remember the second part of the question.
Are the outcomes good or bad?
Yeah, so the outcomes at this moment are unknown. I can tell you I have been to many conferences. That was in a conference just as late as Saturday, and we shared this information with the educators in Texas. And multiple educators came to me and said that they recertified by examination. and they were able to experience the scenario and the items, and they absolutely loved them. I have yet to receive any negative feedback on this. Again, this is anecdotally.
Okay, your next question comes from Rick Foer regarding the scenario-based questions. I don't see how this exam takes the place of testing a student's psychomotor skills. What am I missing here?
Okay, so this examination is the performance examination, and what it captures is this concept of clinical judgment, leadership, and communication. Those had been captured in the integrated out-of-hospital scenario, oral A, oral B, patient assessment trauma, and patient assessment medical. And so with this concept of clinical judgment being picked up in the performance examination at the Pearson VUE Center, we now have to focus in on, well, how do we capture this psychomotor? How do we know candidates are competent in that psychomotor domain, which leads us to this concept of SMCs. So the candidate will be required as an eligibility requirement for examination to show that they are competent in their skills, which will be captured by that SMC. So when you look at these documents, these SMC documents, there is a list of skills that they have to capture in the AEMT or the paramedic program in a portfolio from day one to the very final day. And they have to capture those skills in things like intubation, IV start, medication administration, all of those kind of things like that. The portfolio is the tool that's going to tell us that they have psychomotor competency, and that will be kept at the program level by the EMT program, AEMT program, or the paramedic program as a requirement of COA or a eligibility requirement for the AEMT examination. So because we shifted clinical judgment to the performance component, we picked that up there at the test center at Pearson VUE, and the SMCs will pick up the psychomotor component with this portfolio being on hand for every single student in the course. Again, capturing those skills from day one to the very final day. Long answer to a short question, but that's a great question.
Absolutely. The next question comes from Angel Burba. It was during your portion of going through the scenario-based questions. He asks, I'm curious how the grading of these multiples occurs. He might be asking how the grading of the new scenario-based questions will happen.
Yeah. So currently, all of our items are scored dichotomously, meaning they are correct or incorrect. One of the things that we are studying in these pilot items is, is there a need for partial credit scoring? We don't have the answer to that yet. That is being studied, but I can tell you the scenarios are being written so that there is dichotomous scoring. So for instance, in some of those items we saw, it said which of these signs and symptoms are consistent with hypoglycemia. Pick those 2 or 3 answer options. And so those 2 or 3 are selected. The other ones, I can't remember what they were there, but they were not consistent with hypoglycemia. And of course, those would not be correct answer options. But the answer to your question is we are studying that right now.
Okay, your next question comes from Gordon Cox. When can paramedic candidates expect to see the novel questions, and what estimated percentage of the exam will they compromise?
So the items are currently on the examination. They are on the examination as pilot items. So those are out there right now. Those items that I showed you, those novel items, the build list, the options box, and drag and drop. Those are on the examination now. They are being piloted. And I can't remember the second part of the question.
The second part of the question is, what estimated percentage of the exam will they comprise?
The answer to that is depending on how they perform. And so we are piloting them. We are seeing how they perform. And perhaps there's one item that doesn't perform versus another. We won't use them if they don't perform. If they do perform, we'll absolutely use them. So again, everything's in a pilot phase at the moment, and it'll depend on the performance of these items.
Okay, your next question comes from Angel Burba regarding the psychomotor exam sunset. Can a state influence if they are requiring a psychomotor exams for their graduates?
Yes. Anything we do as educators is at the authority of the state. So the state, for instance, I'll talk on the AEMT side, the state may say, we want to continue to have a psychomotor examination. They will be able to do that in their particular state. It just won't be a requirement for our examination.
Okay, your next question comes from Katrina Adelman regarding the scaled scoring. Are they still breaking up the paramedic exam into modules to pass?
No. So the examination is graded as a whole. And so even though there are domains within the examination, the test is scored as one examination. So the subscales are not scored individually as a pass-fail criteria.
Okay, your next question comes from Angel Burba. What types, and this is regarding the scaled scoring, what types of additional feedback are provided with this report, particularly since it seems it is not domain specific?
So what they will get is this score, and it will tell them how they performed on the examination. It will tell them how far they are from the mark here. This is going to be more precise than when we give you back information about near passes and all of that. Because honestly, when you look at the paramedic examination, it's 80 items on the very low end. And 20 of those items are pilot. 20 of those items are pilot, 60 of those are live. Again, it can be 80 to 150 depending on the candidate. But you're going to get a better picture on the scoring of that examination, because if you have the 5 domains, and I'm making the math super simple here, but if you have the 5 domains and there's 12 items each, we're giving you feedback on as few as 12 items. So for instance, pick operations, I guess I would ask you is which 12 operation areas did that particular candidate see? And so I think what you see is that this score of 840 here is more informative. Again, I mentioned earlier that when a candidate fails the examination, they don't typically just bomb cardiology and do super great on the other areas. They tend to be weak across the board. And so this information will tell you how far they are from the mark.
Okay, Daniel Sachs asks regarding the scaled scoring, can you show how this will appear for program directors?
This is not in my wheelhouse. I don't have an example of that. I will, if you put your name in the chat here, I will reach out and see if we can get you an answer to that.
Okay, the next question comes from Vishnu Sue. Will the scaled scoring detail, oh, you already answered this one. Sorry, let me get a different one. Okay, next question comes from Rick Four. Will the NAEMSE symposium be offered on online or only in person?
Oh, that's a really good question. So the plan right now is to actually have 4 of these events. And so this event right now is going to be somewhere between 6 and 8 hours. The very first one is the one that you see right now, August 16, 2023 at NAEMSE Symposium in Reno. There will be a second event down south, the first quarter of 2024. A third event up north, second quarter 2024. And the final event will conclude at NAEMSE Symposium 2024, which will be in Pittsburgh, which is going to be east. But in between these, there's going to be the same content actually is going to be carved out into 8 different webinars. So if you can't make a live event, you'll be able to capture this and attend this on demand or live in 8 different webinars. And so the particular months have not been selected yet, but they will fill the gap between these 4 in-person live workshops. That will be first west, then south, then north, and then east. And those will play out starting August 2023 and conclude in August 2024. But yes, so you can watch these on demand on NAEMSE webinars. There'll be 8 of them. It will be the same content. It will be just carved into 1-hour blocks.
Okay. And just to keep track of time, we only have about 4 minutes left of the webinar, and we have quite a few questions left to get to. So if we don't get to your question live, we will email you individually with our answers, but we will try to get through a few more here. Kate Soons asks, will program directors need to maintain records of SMC for audit?
So Kate, I know Kate's an AEMT instructor. I know Kate. That will be up to your state, what's going to be the requirement in your state. Again, we're working with NAEMSE to develop that document so that we have a model guideline as to what that would look like all across America. That will actually rest with the states, and what that looks like will be determined by the states. But again, we're working with the states to develop that guideline. So Kate, I can't remember which state. I think you're Vermont. That will be dependent on the state that you actually have your authority from.
Okay. Carl Stein asks, will this type of exam and competency portfolio be moved to the EMT level? If so, when?
Right now, there is absolutely no discussion on that. Getting this implemented at the ALS level is a very heavy lift. And so once we get it at the ALS level, maybe we'll come back and look at the BLS level, but that won't be anytime soon.
Sure. Oh, and I didn't record this person's name who asked it, but someone asked, are pilot items counted towards the student's score?
No, so they are on the examination. The candidate sees them. They answer them to the best of their ability, but they are not operational, meaning that they don't count for or against the candidate. So if they get the item right, it doesn't count for them. If they miss the item, it doesn't count against them. It is just capturing metrics for us to see how it performs and also to decide the difficulty level of that particular item.
Okay, and Dan Limmer asks, will the exam remain computer adaptive overall?
Yes, I have to preface that with the AEMT examination is a linear examination, but the others are caps.
Okay. And Pamela Bertone asks, do I understand that this format will replace the IOOH scenario in the oral stations for paramedics?
That is correct. Those are part of the ALS psychomotor examination. That will be retired on the timeline right there. And so, yep, IOOH, oral A, oral B, that will all be sunsetted on June 30th, or really July 1st. And then the entire process goes away June 30th of 2025. Again, the portfolios, the SMCs are picking this up on the psychomotor skills, and the clinical judgment piece is going to be picked up in the performance component of the ALS examinations.
Okay, and then Angel Burba is asking regarding the NAEMSE workshop. Is it free of charge?
Yes, that is free, but you do have to register. I suspect that NAEMSE would have to answer this, but I'm sure the room for this event will be pretty good size, but there will be definitely capacity limitations for it. Again, we're doing 4 of these in-person events. Again, west, east, north, and south. Okay. But this is the first one. This is the date that I have currently.
All right. And then Dan Limmer asks, who will be responsible to assure AEMT students have completed the SMC? And paramedic, it is COA.
Yep, and paramedic, it's COA. The AEMT SMC will be something that we work together with the states. And so we are making it an eligibility requirement for the AEMT examination. But ultimately, our hope is that the states will make it a mandatory requirement. And they will probably define, we have a document that is just kind of being shared with NAEMSE, Each state will probably tweak that and adjust that to their own wants and desires, but the goal is to have a document that is uniform as possible.
Okay. We do have a few questions left, but we are at our time limit. So if we didn't get to you, I promise we will reach out to you via email. I believe we already have your emails from the registration, but if you have an unanswered question, please put your email into the Q&A or the chat. And thank you all for taking the time to be here. Paul, Rio, do you have any closing remarks for everyone?
Nope, I just say thank you for attending. It's really excited that you're here. So just stay on top of this. A lot of things are, rolling out right now with Registry, and it's a really exciting time to get to use some of these TEIs and see how they perform and test this concept of clinical judgment.
All right. Paul and Emily, thank you both so much for being here with us today. We are always so excited when we get to collaborate with NAEMT. So everybody, I will make sure that all of the information and unanswered questions make their way over to Emily. And I put a link in the chat to obtain the CEU from the webinar today, but in case you missed that, there are no worries because a follow-up email will go out tomorrow, and I will make sure I include all of the links that Emily sent, as well as a link to the recording and a link to the PowerPoint presentation. So with that, I believe that's everything. So I hope everybody has a great rest of their day, and we will see you next time. Bye.